RN for 25 years and was always a patient advocate. First and foremost, she founded Patient Pathways and has been acting as an independent healthcare navigator for almost 8 years now. She knows that patient and care partner empowerment are the keys to getting the care you need and deserve. This webinar is part one of a two-part education series. During this webinar, you will learn about the different pieces of our healthcare system and what you as a care partner can do to navigate transitions for your loved one. Whether your loved one is transitioning from an acute care episode back home with home care services, between home and facility-based care, or even between palliative and hospice care. This webinar will help you understand how you can support these moves to ensure the best continuity of care possible. Today, Connie will be sharing her extensive knowledge and resources on this. Connie, thank you so much for being here today and welcome. I'll pass it over to you now.
Hello, everybody. Thanks so much for being on this webinar today. A couple of things before I get started, a little bit more about me. I was a registered nurse for 25 years, 15 of that in cardiac care. So I got to know the healthcare system, the inside of the healthcare system pretty well. It's been the outside of the healthcare system that has been a pretty big learning curve. And so I just want to share some of that with you. There's just about nobody that I haven't, no kinds of situations that I haven't helped patients and families navigate. And I am an advanced care planning specialist. Early in my days as a navigator, I realized that really important conversations and documentation need to take place with people who with complex and serious illness. And then it is in fact a really important conversation for every adult of every age at all levels of health. And so I'm going to do a deep dive on that next week, and I really hope that you'll join me for that. I am dealing with navigating the BC healthcare system today. It's where I live, it's where you live. But as you're talking to friends and family across the country, the differences between every province are really quite profound. Our healthcare legislation had to have some standards, so there's the same kind of language around a lot of things in every healthcare uh, legislation across the country. There is no overriding legislation at the federal level. And so if you're talking to somebody in Alberta and you're talking about becoming a representative or them becoming a representative for you, they won't know what you're talking about. British Columbia has some of the most in-depth healthcare legislation across the country. However, there's not a lot of enforcement or organizations who enforce that legislation. And so it's really up to us as empowered patients to make sure that we're getting the health care that we need and that we deserve. I just wanted to let you know that I strive to empower patients and the people who love them. We all have different names for the people who provide care, and often this role are the wives, daughters, and daughters-in-law, but there are sons and husbands who are looking after their loved ones. And we're going to go into that next week as well on substitute decision makers. I have a book out, and at the end of this presentation, I'll let you know how you can order the book. What we're going to do is provide the PowerPoint to everybody who wants it. But what I'm got going today is a teeny weeny little snippet of what's in the book. So I encourage you to buy that and put it into your in case of emergency binder, because I cannot imagine that you would need all this information now, but if you're heading into a healthcare crisis, you may need more of it. Serious and complex injury and life-ending diagnosis can and do happen to anyone of any age. The bulk of my clients are in their senior years, but fully a third are in their 30s, 40s, and 50s. We're more likely to have very serious illness take place in our 20s to our 50s. And so it should not be ignored by people who are younger. So become an empowered caregiver. Complex chronic illness is a marathon and not a sprint. People get burnt out from this, and I'm sure that you've been on multiple webinars like this before. How do you take care of yourself? And one of the ways that in this context is to build your team, the people you can rely on to give you a helping hand. We tend to become some people tend to become even more withdrawn from the world as they are dealing with somebody who they're looking after. My mother was certainly that case. My mom was an extreme extrovert, out in the community, belonged to absolutely every organization. And as my dad's illness got worse and worse, he needed more and more care when his dementia really started to take hold. Her ability to be out in the public became very limited. And it was a very big shock for her. So I'm asking you to actually think about reaching out to some of those people and build your team. You do not have to be all things to the person you are caring for. What could others do as well or better than you? Find them and let them do it. That can be what the hardest part of all is, letting go of some of the things that others could do for you just as well. And what plans and team do you need to build for yourself? Loved ones and care partners often go down first because they are not looking after themselves. I found this as a cardiac nurse on a very regular basis. The most profound was when I was admitting a gentleman who was having chest pain, and I asked him how his wife was going to do at home. She was his primary caregiver, and he said she's going to do just fine. What we didn't know was that she was being admitted downstairs in the emergency room for a massive heart attack at that moment. I often see where the person who is the caregiver becomes ill first, and then there's a full-blown crisis on the family's hands as the person who is being given care needs to be put into care on an emergency basis. Use those who will manage your health, finances, and estate carefully. Get your paperwork in order and talk to those who might one day make decisions for you about your values, beliefs, and preferences for future care. Sometimes this isn't the person that you would automatically think. So if you were the caregiver, think about if there's somebody else who would actually be better in a crisis. Think about whether there might be somebody who's actually better at doing the finances, or if you can hand that job over to them. You are going to have your hands full if your loved one ends up in acute care. And if somebody else can take on the roles of talking to the doctors, finding out what's going on with the health, taking care of finances, it will lighten your load considerably. So the question often is money versus health. And we all have to make these decisions every day. So there are several roles when you're doing estate planning, and these circles are actually documentation. There's the enduring power of attorney, which is for finances and any investments that you might have. Make sure that that person is, number one, knows how to balance a checkbook, can find their way around a bank account, and that you trust them implicitly with your money. If you don't have somebody in your life who you trust implicitly, it is a financial cost worth bearing to go to a trust company, to a lawyer, or to your bank who do have a trust company. Often have divisions. There are trust companies that are nonprofits. And in my book, at the end, I have several of those kinds of businesses listed. One of the things that people think that an enduring power of attorney can do is speak about your healthcare. In British Columbia, that is absolutely not the case. An enduring power attorney has absolutely no say whatsoever in your healthcare. The only time an enduring power of attorney is in place is if you are going to home care or going to be receiving home care or going to residential care. In that place, the enduring power of attorney may need to provide notice, the Canada Revenue Agency's notice of assessment for your last tax year. Doctors and nurses get this one wrong all the time, and so you now have more information than 80% of doctors and nurses. Social workers are often a really good person to reach out to in the community and in the hospital about advanced care planning. They can help you put an emergency representation agreement in place if that is needed, as long as the adult is still capable, and I will talk about that next week. So a representative is your health representative. They are able to assist you and make decisions for you if you are not capable of making those decisions yourself. And it is through a representation agreement. It's a very simple but very powerful document, and we'll be going over that next week. An executor is for your estate, for your will, and that is I won't be going into that. It's not my area of expertise, but I do encourage you to take the time to go to a lawyer and make sure that your will is done properly. I see a lot of pain and grief when the wills have not been done properly. And most people do not need a guardian and or trustee, but in some situations that's necessary. So you may name one or more person for several roles, but separate documents are required. Put copies of all relevant documents in a clear folder or a binder. In Fraser Health, they have a green sleeve, which doesn't hold very much, but in the green sleeve, you can say where that information is and place those documents beside your fridge, or put a clear note on your fridge indicating where these documents can be easily found. So many of us have stainless steel fridges, or we don't want other people to be seeing our information. Just put a clear note of where your information is. It is the universal place for first responders and paramedics to look. And Fraser Health has now had an agreement with first responders and paramedics that they will indeed look for that. And I'm going to be fighting to make sure that that is happening on all other health authorities as well. Give copies of your important documents to your substitute decision makers, your representative, your enduring power of attorney, and your executor. Please let them know what these documents are for and where they should be kept. One of the most important people on your team is your family doctor, also known as a general practitioner or a GP. We use the term GP because it's easy to say, but most family doctors are now certified family doctors. They've gone through a special residency to be a family physician. They are to act as your quarterback for all referrals and the hub for all testing. So even if you are going to a walk-in clinic because you can't find a doctor, it is now the law under the College of Physicians and Surgeons that if you have attended at a walk-in clinic more than twice, you are considered a patient of the clinic, and they are to follow up with all referrals and testing. If you, and this is a very high level conversation regarding finding a doctor, because I know that a lot of British Columbians don't have a good doctor, or they don't have a doctor at all. Problem is that some doctors are not great doctors, but under the College of Physicians and Surgeons guidelines, if you've already got a doctor, it is going to be very difficult for you to switch doctors. You can let your doctor go say, I don't want to see you anymore, then you are doctorless, and then you can go and find a new doctor. So what I recommend is like just going and finding a new job. You don't tell your old employer that you're leaving the job until you found a new job. So go out and find yourself a doctor, and then um, get rid of your old doctor. Say that I will not be a patient in this clinic anymore. If you need a new doctor, there are no magic cures. There is no longer it's not on the College of Physicians and Surgeons website to find one anymore. But most emergency rooms and urgent care clinics can refer you. Take friends' recommendations and see if their doctors will take you on, and continue to contact local clinics to see if there are new doctors taking patients. Do your homework, check on WebMDs for consistent comments. So sometimes I will see um, consistent comments that the front end staff are rude, but the doctor themselves is lovely and responsive. It's more important that the doctor is responsive rather than the front end staff. Um, but if you're seeing wildly varying comments, be concerned that this doctor is padding their reviews with positive comments. So take a really good look at that. And if you're being sent to a doctor, and don't hesitate to tell your own family doctor if you're going to a specialist that you don't want to go to a certain doctor. I actually will find the best doctors online for a certain specialist or for a certain client. So they need to see a neurologist, um, or they need to see a Parkinson's neurologist specifically. And then I do who are the top doctors in Vancouver for that. Look those WebMD ratings up, and then take that back to my family doctor. Find doctors who will listen and trust you as an intelligent, well-informed patient and care partner. I've had doctors who have actually said, I am intelligent, well-informed, and I expect to be treated as a care partner in my own care. And that has changed the way that the doctor has treated me. Do your homework wherever possible about specialists best suited for the issue, and give that list. So the next piece is empowered communication. Effective communication is absolutely everything for thorough and safe, effective care. As a health navigator and patient advocate, I have no other tool in my toolbox than communication. And I've learned how to do it well. And I'm going to give you a few hints on how to do that. Be respectful, respectfully assertive, stay logical, and try to be kind and understanding even when it doesn't feel like it's being earned. So respectfully assertive is not being passive, not being aggressive, and just saying, my care needs are currently urgent. I need to talk to the doctor as soon as possible and about the following: A, B, C, and D. Stay logical. This one is hard work when you are feeling overwhelmed and emotional, but just think of it as a switch that you're going to turn on and off. For the next 5 minutes, when I'm talking to this doctor, I am going to stay in a logical headspace. Doctors don't perceive people who are overly emotional um, as being as engaged or able to manage their own care as somebody who's staying logical. And try and be kind and understanding. I understand that your office is very busy. Um, I have been trying to get through for the last 4 days. I would really appreciate a call back as soon as possible. This is an urgent issue for me. Organize your health information. The majority of the time, I find a very big mess when I'm asked to go through a client's information. Um, there needs to be some kind of order to the information that you have on hand. You know, lab work should all be together. X-rays, MRIs, and those kinds of things should all be in separate folders. I go into that in my book and how you can separate those. And they should be in some kind of chronological order so that you can find them. It it's really wonderful when when a patient brings in all of their healthcare information to a new specialist, but when the specialists see that it's a disorganized mess and the patient rummaging through it for certain information, it is not as heartening for the doctor, and they do become impatient. It's really important for a lot of reasons. We forget important details and dates. Important documents are frequently lost, or your doctor may have archived them. And some of them, if their practice is closing, may sell to an archive company that can be more than $100 to retrieve. And we don't know what's important. As a patient, that's not our job. It's a doctor's job. But having all those papers together is really important. And we don't know what other doctors and health members have reported and recommended. The number of times that I go through reports, and at the bottom of, say, a CT of somebody's head, it says an MRI of this or a functional MRI is highly would be very helpful for this patient. And that has never been followed up. So it's important that you at least read it for that. But I also ask you that you don't take reports that you receive and take them personally. So recently I got a phone call from one of my clients who had gotten an x-ray report. This woman was 72 years old, and it said, this geriatric patient is blah, blah, blah. Well, there are certain reasons that within the healthcare system, a person is deemed geriatric. And over the age of 65, that is the case. In maternity, if somebody is over 35, they're considered a geriatric patient. So don't take that personally. These doctors are using medical jargon to describe what's going on, and it's nothing about you personally. Really important is to obtain your hospital records, which are only available after discharge and take approximately 30 days. What you need to do is just Google the hospital or an agency and health records, or obtain my health records and then put what city that you belong to, and it always comes up. You're entitled under law to your health records, but be careful to try not to interpret your results. Ask a professional for advice. So there are a lot of scary looking things when you look into your health records, and it's really important that unless you understand them intimately, that you don't interpret them yourself. Take those, use a yellow highlighter and go to your GP and say, what does this mean? Communication in case of emergency costs lives, it costs time, and it is extremely important. My team and I have put together one of the most in-depth in case of emergency forms available, and it is free for you to use. So you need to plan ahead for emergencies, because during a crisis, your mind will be blank, it could be black too. There might be mass chaos. There can be as many as 12 to 20 people in the room. Important details may be forgotten. Every person, no matter their age, should have an in case of emergency form completed and immediately available. The ICE form is in the book and can be found on my website at patientpathways.ca under the tab Plan Ahead. It is fillable, downloadable, printable, and easily updatable. A few additional things for you to think about. Do you have someone else in your home that will need care? So as a care provider, who are you caring for, and who would be your backup if you ended up in the hospital? Clearly indicate that and who the first responder should call. Hopefully it's somebody like a neighbor who's immediately available to come by. So if you have a neighbor who will come by to look after the person you're caring for, make sure that they have the contact information for your substitute decision makers. Make pre-arrangements for your pets and have those clearly indicated on your documents. So at the beginning of this COVID pandemic, And now, with our increasing rise in numbers, I am concerned about what will happen to my two cats if I became suddenly ill. So I've made arrangements with my neighbors to be able to come into my building or into my suite and to call my daughter who will come and get my cats. Let somebody know where all your relevant account and computer passwords are. This one I should actually have in red and flashing lights. Um, I get so many phone calls from families who are just fit to be tied because their loved one has ended up in hospital, is no longer capable of telling them where the passwords are or what the passwords are, or they're slipping into dementia and the passwords are all over the place or in that person's head. This needs to be of primary importance as you're moving forward. Okay, finally, we get to half an hour in, we get to navigating the healthcare system. I'd like you to take a deep breath. If you're taking notes, just try and follow along as quickly as you can, knowing that you're going to get this slide presentation and that you can buy the book so you don't need to memorize everything that I'm about to say. Each part of the system has its own policies and procedures, and they are very different between every city and every health authority. When I was asked to do this webinar, it was supposed to be for every part of British Columbia, and that is impossible because even within a hospital like Vancouver General, there are pieces between each of these. Often within a ward, there are different people who are looking after different pieces of the healthcare system. And it's really important that you take notes and you ask questions and you find out who is responsible for who. So doctors and specialists are a team unto themselves. Your G, and I'm going to go over how to get referrals seen more quickly. Used to be in the olden days that the doctor would pick up the phone and talk to a specialist and say to them, you know, I've got Mary Smith here, and she has A, B, C, and D. Would you see her? Doesn't happen like that anymore. We have the antiquated system of fax machines, which is how things are communicated, and I'm going to go over that in a minute. Serious illness and injury usually involve going to an emergency room, and emergency rooms may be attached to a hospital, but when you're in the emergency room, you're actually not a patient of that hospital. And the transition from emergency room to acute care will be a completely distinct process. The acute care hospital in itself, especially if you're from a smaller town, can be extremely daunting. If you are being transported to St. Paul's Hospital or the Royal Columbian or Vancouver General Hospital or Surrey Memorial, they are cities unto themselves. And it's really important that you find out where your loved one is going and then who is who in that department. And I'm going to go over that. Home care is another piece by itself, and often there are subdivisions within home care, and I'll be going over that. Residential care can be assisted living and long-term care. There is private and public, and sometimes there's a combination of private and public, so I'm going to go over that. And then what is palliative care and hospice? All of these are different divisions of our healthcare system. When you understand how the system works, it's easier to communicate with the right people. There are silos within healthcare settings, and there are many departments under one roof, and they are likely to not talk to each other. So when your loved one is going for surgery and you're waiting for them after surgery, you probably won't find out anything until they arrive back on the ward, and they won't, and the nursing staff on the ward won't know anything until the moment they arrive. So it's important to find out, you know, can I talk to somebody in the recovery room about how my wife or husband or my mom or dad are doing? The most important part of being an empowered patient or caregiver for one that you love is to take and keep notes. It's the most important, powerful tool in your toolbox. I actually recommend that you have a binder or some kind of binder or that you can add and remove pages from so that you are not, don't have several different notebooks on the go. So this is my Bible. I've had this now for 8 years. It's from Staples and it has the ability for you to put tabs in it and to be able to remove the pages and add more. So when I am finished with a certain page, or let's say your loved one has finished with a certain kind of treatment or there are no many more notes to be taken, then you can take those out and put those into a special file so that you're not filling up your binder. So, but what do you say in this notebook? Who did you see? What is their role within that department? What did they say? What brought you to the appointment? What were your concerns and questions? Where were you? What hospital? What ward? What office? What emergency room? When did this occur? The date and the time, and why did you see them? So you're being a reporter during this time. When I attend appointments with people, there can be information that's all over the place. It's not coming out in this lovely W5 format, but I take the notes and then I transcribe them as quickly as possible. So hopefully within the day, and I put them into this kind of order. Then I send it on to the patient's family. So in your case, you can send it on to other loved ones with a bit of an agenda, as it were. You know, dad saw this doctor, and this doctor today. They recommended this kind of treatment that will be followed up when, and we expect this to happen in the next few days. Write down important appointments and put those onto your calendar so that you can remember. Write yourself tasks in a place that you're going to remember to do them. So when a doctor says, follow up with me in 2 weeks, you write that on your calendar. You need to find out who is who in this maze, and that is just probing and questioning. Who is the best person for me to talk to? Who makes the decisions and has the information? In doctors' offices, there's the person is called the medical office assistant, or quite often they're called the assistant or the secretary. In hospitals, the unit clerk, who is the unit secretary, or the patient care coordinator, also known as a unit manager or head nurse. They are there every single day and have the best understanding of the patient. The nurse may be on for 2-day shifts. She may be on for 2 night shifts. There may be a different nurse every single day. So it's better to go to the patient care coordinator and find out what's going on. Who's responsible for the specific parts of the care? For example, the physiotherapist does exercises and mobilization, or the occupational therapist is often the key person in discharge planning and equipment at home that might be used. The other person who I forgot to put on this list who is of vital importance is the social worker. Social workers are not somebody that you will be introduced to, it's somebody you need to ask for. They know about advanced care planning. They can help with financial, and they are often a key person in the discharge planning process. So what doctor or specialist is in charge? In smaller hospitals, many GPs are still still have privileges, and they will ultimately be in charge of you. But in the larger hospitals, it may be the hospitalist, which is like a hospital family doctor, or a senior resident. The specialist in charge may be called the most responsible physician or practitioner, because sometimes nurse practitioners are now in charge of patients. And so they're called the MRP, and they should oversee care, orders, and discharge planning. In the bigger hospitals, when you have come out into hospital with multiple issues. So for instance, say you came in with a stroke, but it was a result of being a heart atrial fibrillation, you may be assigned two specialists, a neurologist and a cardiologist. Find out which one of those in charge and who will be following the patient throughout their stay. Usually it's the first admitting doctor that specialty who will be in charge of you. This is really gets lost in the mix in big hospitals like Vancouver General and St. Paul's Hospital or Surrey Memorial Hospital. It's up to you to find out who's in charge. Sometimes you'll be lucky and it will just be the hospitalist, but hospitalists change usually every week or two as well. So it's important to keep on top of that. Deep breath. I'm trying not to overwhelm you. So remember to go back to this recording, go back to the presentation, go to my book to find out who these people are, because you don't need all of this information now. This is an elephant. So just take the pieces that you need as you go through. The other thing that I forgot to mention at the beginning is that this is a really high level discussion. Some of you are just coming into, have just become caregivers. Others of you are veterans. And the veterans likely have some pretty big stories on how this did and did not work for them. I would love to hear your stories and see if I can help. Please don't hesitate to send me an email and see if I can just give you a quick answer and let you know how to move forward. I know that this system does not work properly for all people, but the more that you know how it works, generally the better it works. So for all those people that I just mentioned, the doctors, the nurses, the occupational therapists, etc., write down their names, their role, and the phone number and extension. Really important to write down the extension, especially in the big hospitals. Keep it handy and refer to it. And when you call and identify somebody by name, it engenders trust, and greater cooperation. So if I've been talking to the unit clerk for the neurology unit, at Vancouver General, I'll get her name, which is Jane, and the next time I phone, I say, "Hi Jane, this is Connie, and I was talking to you yesterday about Mr. Smith. You put me through to the patient care coordinator, whose name was Betty, and I was wondering if Betty's available and if I could speak to her now. If you have a first name, and for even a last name, it can help you be put through to the right person very quickly. And it sounds like you know what you're talking about. Okay, so you're leaving hospital or you're leaving the BC Cancer Agency or you're leaving a certain service. The time, the transition between one service and the other service um, is a dangerous point in your care. It's where things get dropped. If you think of it as a baton being passed, if it's not passed properly, the baton is dropped, and sometimes it can't be found. So it's really important that you follow up on these transitions. The key ones are between family doctor to specialist, between acute care to home, and then or to residential care, from home care to residential care, which can be assisted living or long-term care, and cancer agencies to palliative care and hospice. This is where the places where I have found that paperwork gets lost and communication is broken. Be proactive, be on the offensive, be assertive. Follow up, follow up, and follow up. It drives patients and families absolutely crazy. They've hired me and I go into a situation and I get the answers, or I get a referral, or I get a date within a few hours or a few days, and they ask what I did. I'm a bit of a pit bull when it comes to following up. I will phone a specialist's office and say, "Hi, I'm Connie, and I will explain what I do. I'm following up on Mr. Smith's referral to Dr. Jones, it was sent by the family doctor on such and such a day. I just want to ensure that you have it. If you do not have it, please call me at and my phone number. So I'm assuming that if indeed that was taken care of, that they're not going to call me back because it takes a lot of time for them to do that. If I haven't heard from them within, um, heard something within a short period of time, I follow up. So in my case, I had a cancer spot on my back last year. It was an easily treatable cancer, but I did require some surgery. And then I had another couple of spots that I wasn't completely happy with. So I asked my family doctor to refer me again, this time to a dermatologist and not a dermatology surgeon. And she put that through. And I wasn't overly fussed about it. They were not things that I was worried about in the least. But 3 months later, I still had not heard anything. So I phoned my GP's office to find out what had happened with that referral. Oh, Connie, we're so glad that you called. That was sent back to us for not enough information. And so we just need to ask you a few more questions and then send it off. It ended up going back to my dermatology surgeon because that's the person that they read on the file. And then when I went in to see my dermatology surgeon and I had questioned that, he said, "What are you doing here seeing me? You are going to the wrong person. You need to see a dermatologist." So one little thing, and it turned into something really major. When you're waiting for a life saving or a life um, extending or something that's going to make your life better, that kind of treatment, it's really important that you follow up on those kinds of things. I hate fax machines. Fax machines are responsible statistically for 1/3 of the time they are not received or don't have enough or correct information. I find that it is probably closer to half. Never assume that the fax went through or is being handled properly. Find out who the fax was sent to, when, and what was said. For example, was it urgent or emergency? Please ask your doctor when you're asking for the referral to take the time to put a lot of information in. If a gastroenterologist has received a fax that says, "Please see Mary Smith, she's had increasing abdominal discomfort for the last year," that puts you at the very bottom of the list. But if the doctor has put in the pain is now severe, she is having nausea and vomiting, is having blood in her stools, that changes it to a completely different way that that information is handled. Um, so I know that it's difficult to ask your GP, but if you develop let your GP know that you're an empowered patient or a caregiver, you will engender trust and they will review that on a more thorough level with you. If your condition worsens, tell your GP, ask for that the testing or referral is updated. And if you have the name of the specialist, call the office and let them know why you need to be seen more urgently. So as a cardiac nurse, I was doing a special project and we were following up with patients who were waiting open heart surgery. And there were a good number of patients who had died on the waiting list. And when we asked, they said, well, we let the doctor know, we let the GP know that his chest pain was increasing, or that he was having more symptoms, or she was having more discomfort, and that was not referred on to the specialist. So it's really important that if your condition is getting worse, that you let both your GP and the specialist know. So back to hospitals for a second. A special note about discharge planning from the hospital. This is the most dangerous transition for patients, especially when the admission was unplanned or an emergency. So if you are having planned surgery, such as your gallbladder being removed, the admission staff, pre-admission staff, make sure that you've got somebody to go home to, that somebody's picking you up from hospital, and all of the post-op instructions are given to you even before you have surgery. But if you've broken your hip and you end up in the hospital, guaranteed that your discharge is being planned the moment you arrive, even though you're in the middle of a crisis. Stay on top of this. Don't assume that you will be given notice. The doctors are not in charge of discharge dates, and they have no authority to delay a discharge. I think that that one's a really big one for families. They assume that the doctor is in charge of when the patient will go home, and it really is not up to him. Once he says that the patient is medically stable, then a discharge will proceed. And you need to make your case for if the patient is not safe to go home or will need home care or will need residential care. If all of that, if you have asked for a discharge planning meeting, if people are not responding, that is a time to go to the patient care quality office and let them know that this is an urgent matter. Otherwise, they will take their time getting back to you. Does the patient need additional care, such as public home care, be that public or private? And if public home care will be put in place, when will the assessment take place? And what will you do until that can start? So often patients are discharged home. In fact, all the time now, they're discharged home without home care actually being in place. It may be the worst that I've heard is 2 to 3 weeks before home care comes in to just begin to do the assessment. Whereas the first few days at home can be the most dangerous. If you're in a situation like this and you can afford it, I highly recommend that you get private home care agency in to help you out with that. The hospital is not going to recommend it, but I've seen where it has actually saved patients' lives. It is expensive. It's anywhere from $32 to $38 an hour, minimum of 4 or 5 hours a day. But if that's the difference between life and death for the first few days, then I think that it's worth it if you have the financial means. Is there any special equipment that's needed? If you can't afford it, if basic equipment is fine, then ask the occupational therapist at the hospital for a requisition for Red Cross, where you can get most equipment. Can you rent it rather than buy it? And what if it is not safe for the patient to go home, even with home care? This is a whole presentation by itself. And it's the number one reason that I get called in on with patients. And if you take the patient home and their condition worsens or conditions are unsafe, call an ambulance and send them back to hospital. It means that they just couldn't manage, and the hospital's actually looking to see if somebody failed at being at home. So it's important that you not try your best. It's important that you don't work really hard um, at trying to keep your loved one at home. If it's not working, if their condition is not safe, if their condition worsens, send them back to hospital. You will see that there is a lot of information on this slide. And so I'm just going to leave it up to you to read a lot of it once you get this presentation later. So there's a big difference between subsidized home care versus private home care. During this time of COVID, subsidized public care has really, really taken a hit. It was in crisis before, and now I would say that it is beyond crisis levels. Do not rely on private home or public subsidized care, especially being put in place now. Going to hear some people say that in the healthcare system that it's working just fine, and well, I can give them a few thousand examples of the times that it isn't working right now. So a few myths. Public home care is free. It is not. It can be a financial burden for families. Usually the case manager will base the subsidized fees on both the husband and the wife. If the loved one is living with a son or daughter, they might include that income. I would thoroughly protest about that one. But between two people who are making absolute minimum of on CPP and OAP and maybe GIC, doubling that income can really increase the amount of the fee. And it can really put a damper on a couple who are just making it as it is. So I've gone to several talks with Isabel McKenzie, the Seniors Advocate of BC, and she said that the government fully expects that families will dip into their savings and even get lines of credit against their home and to buy down the nest egg they have in place in their home. Um, she's very open and very honest that's a full expectation. Families don't think that that's fair. I agree. Um, but there's a big difference between somebody who's got a $5 million home in on the west side of Vancouver versus somebody who's living in subsidized seniors housing. And so they're trying to say that we do live in a socialized healthcare system and that if people have the assets, they're expected to pay for it. So subsidized home care is non-medical care only. There is virtually no nursing care whatsoever these days in homes unless somebody is extremely ill or has very complex dressings or they're immunocompromised. There have to be some pretty big reasons why nurses will come into the home. You're expected to go to a centralized facility to have dressings changed, to have drains removed, and those kinds of things. So it's usually only assistance with activities of daily living, bathing, transferring, dressing, toileting, etc. Due to staffing issues, it is often not the same care aide in every shift, and the case managers often have 100 clients or more. So availability has always been limited, but it has become critically low during this pandemic. So an important note about subsidized public home care in relation to residential care. If you think that your loved ones will need residential care in the future, it's vital to establish a relationship with home or community care now to be known to your local community health branch. Many families are trying to manage this on their own as long as possible or put private home care in place before reaching out to community health, but this can backfire. Community health will want to see how they can help the patient at home before assessing and putting them on a wait list for assisted living or residential care. Reach out for assessments and services early. Anyone can ask for an assessment. So as the caregiver, the doctors can do it. Anybody at all can ask for an assessment and an intake. Call your local community health branch and ask to be put through to intake. And if you get an answering machine, be very clear about the patient's name, personal health number, best contact numbers, and the level of urgency, and then follow up. I've seen these intakes take 3, 4, 5 weeks for somebody to get back. If you're in a situation where you need somebody quickly, please follow up with them and let them know why it's urgent that they follow up with you. So private home care is expensive. There's just no ifs, ands, or buts about it, but it can provide incredibly higher quality of care. It can improve somebody's quality of life, and it can extend some people's lives. So in Vancouver, and I don't know other cities, I know that other cities where it's not as expensive, for somebody to operate a business, these rates can be lower. But be very cognizant when you get a really low rate offered to you. Average rate in Vancouver is 32 to 38 hours, $38 an hour with a minimum of 4 hours a day, 3 days a week. So you can see where 40 times 4 times 3 can really start to add up to a huge number. And if somebody needs more than that per day, obviously that's going to really increase. At some point, it becomes as expensive as private residential care. It's all up to the patient and the family whether they can afford this kind of care and how long that they can manage this financial burden. You often get what you pay for. Beware of hiring independently, so such as nannyservices.ca or Craigslist. Quite often these caregivers just don't have the experience you need. Yes, they're only charging $18 an hour, but they have no oversight whatsoever. And they tend to, I have found, that they tend to give no notice when they're taking a day off, which really leaves families in the lurch. When you're working with a big agency who have a lot of care staff, if somebody calls in sick, they've got backup staff to cover that. Care is unlimited in scope and can usually be whatever you need it to be, including meal preparation, shopping, and light housekeeping. Many agencies can work with community health caseworker in public home care to enhance all care provided. So if public health is offering 2 to 3 hours per day, split up over 2 or 3 hours, that can be combined with private home care with most agencies so that they're not doing the same tasks. Many good agencies are now offering palliative and end-of-life support, and this is very important due to limited public end-of-life support and limited hospice beds in many communities. As a full disclosure, I am now working with an agency called Home Care Assistance in teaching advanced care planning and palliative care and hospice to their case managers and to their care team, because I really feel it's important that this very specialized kind of home care is taught properly. Okay, so we are now at the 12:30 mark. If you do not need to know about residential care, palliative care, and hospice, and if you need to go, please, this would be the point to log out. Remember that this is coming to you in via link so you can go over this at your leisure, and that you'll be sent this presentation. It'll probably take me about another 15 minutes to get through this, and then hopefully we'll have 15 minutes for questions. So what is residential care? There is a lot of confusion about what assisted living and long-term care are and who qualifies for both of them. Public subsidized residential care is not free. Rates are based on 80% of income of the patient. It is not based on assets, and subsidized rates are capped at approximately $3,400 a month. So if somebody qualifies for subsidized care, it doesn't matter whether they are on absolute minimum government assistance or if they have a home in Shaughnessy that's worth $8 million. The least that you will pay is about $1,000 a month. The most that you will pay is $3,400. Like public home care, this can be a significant financial burden on the family. Families are expected to dip into savings and nest eggs, such as the value of their home. And again, that's per Isabel McKenzie of the BC Seniors Advocate. Residential care in public subsidized care in privately owned facilities. This really confuses people. So I just want to be really clear. There are only a small number of residential care facilities that are actually owned and operated by the health authority. These are listed on the health authority website. Most residential care facilities are owned by private organizations or conglomerates, such as Rivera or Retirement Concepts, big multinational corporations, and sometimes, often actually, by nonprofits such as the Rotary or Kinsman or churches. They lease some or all of these beds to the health authority, and the rates for these beds are the same as for a public facility. So let's say your loved one is going to Royal Arch in South Vancouver. That is run by the Rotary Club. They have their own board of directors, but 80% of their beds are leased to Vancouver Coastal Health. 20% of their beds are privately owned or are available for private. And I'm going to go into that in a second and why that's important. In these facilities, there may still be private beds, and this is important for families when considering placing their loved one earlier than they would be able to in a public bed. Or if a public bed will not be available for 6 to 18 months, you can ride out that period of time by privately paying for the facility of choice, waiting for a publicly funded bed to become available. Okay, so there's a difference between assisted living. Both public and private are the same for this slide. Assisted living is generally for those with physical and mild cognitive disabilities that require meal preparation, medical queuing, and less than 2 hours per day of non-medical care. Residents must be able to direct their own care. So I have a lot of client families who come to me wanting to put their mom or dad or their husband and wife into assisted living, feeling that with their moderate dementia, that's the next step for them. If somebody has moderate dementia, they are probably already too late for assisted living. Usually it's assisted living is for somebody who is in a wheelchair or uses a walker and needs to have their bed made, needs to have assistance with showering, needs to have their meals made for them, but they only need 2 hours a day of non-medical care with bathing, dressing, those kinds of things. They need to be in a facility. There are only a small number of assisted living facilities, both private and public, and these serve a different need than long-term care. It is generally not the first step to long-term care. It's actually quite different between assisted living and long-term care and who belongs in which one. Long-term care public is quite different than long-term care in a private bed. Long-term care is only for those with significant physical care and advanced cognitive disabilities that require 24-hour non-medical and medical care. It is really important that if you've got a loved one who is looking for them to go into residential care, it is vital that you get a representation agreement in while that person is still capable of making a decision. And please, if this is the case for you, please attend next week. Representative has much more authority to make important decisions regarding placement. You will be asked for your top 3 long-term care facilities. If the need for an urgent placement is high, such as the person is unsafe to look after themselves at home, or they're at risk, such as leaving stoves on, wandering, frequent falls, then an interim placement will be recommended. And this may not be your top 3 and may not even be in your community. So I've seen people who are, the loved ones are in South Vancouver, who are, they are placed as far away as, well, actually, it tends to go the other way around. Let's say somebody out by UBC and their loved one is placed in a facility as far away as Marine Drive and 56. So it's an hour and a half, 2-hour commute across the city to be able to go and see your loved one. You remain on the top 3 selected list until one of those beds becomes available. This can be really stressful for families to have their loved ones separated for as long as 6 to 18 months. The one concession that the government has made is that couples who are in residential care, they are first priority to be placed together. So if interim beds were needed for both of them, so both of them went down and needed care at the same time, then every effort is made to put them into the same facility as quickly as possible. Long-term care emergency placement is usually made from a hospital. It is only for those with significant and physical and advanced cognitive disabilities that require the same 24-hour non-medical and medical care when home is not an option. Again, it's vital that a representation agreement is done as soon as possible while the patient is still capable of making decisions. All health authorities have a home first policy, and they push that really hard, where every effort is made to put care and equipment at home in place. If you do not feel that the adult is safe to go home, you may need to fight for residential care placement. That is where somebody like me comes into play. If the adult is deemed appropriate for long-term care, you will be asked again for your top three, but an interim bed will be picked to put that person into. And that hospital to long-term care is the #1 priority. And so that can happen pretty quickly. And again, you will stay the top three facility placement. They will be transferred to your top three favorites when the first bed becomes available. So you can't say #1 is the Taj Mahal, 2 is this is Hotel Riviera, and 3 is whatever. Whichever one of those comes up first of your long-term care facilities is where your loved one will land. So be careful when you're picking those top three that they are the three that you would want your loved one to go to. Know that the best facilities have the longest waiting periods, and some of them are now approaching 18 months to 2 years. Residential care, private assisted living, and long-term care are a bit of a different animal. Going into private care allows families more flexibility in where the adult will be placed, with a much lower threshold of need for care. Many fully private facilities have both assisted and long-term care, allowing a gradual increase in care as needs increase. Many private facilities also have publicly subsidized beds, which allows the adult to switch from a private to a public bed when the need arises, or when a bed arises or the threshold of need has been met. Be sure that the facility can switch the patient to a subsidized bed. Some don't have these available. So for somebody who's got increasing dementia, it is going to cause them a lot of pain and anguish to be moved from one facility to another. So be cautious in going to a private-only facility. Private care can be extremely expensive. Rates vary widely depending on the community or the city. So North Vancouver is the highest, Vancouver is second highest, and if you get out to Burnaby, to Surrey, or to Maple Ridge, the rates start coming down. So if it is not a concern about friends or family being able to access the patient, such as family being already living out of town, then you might want to consider moving your loved one to a facility that's further out of the city. If a private bed is being taken while awaiting a public bed, the adult is considered safely housed, and the wait can be 6 months to a year to get a subsidized bed. So once you've picked this private bed, you have been deemed to have put your loved one in a safe place, and they are now not a top priority for a public bed. When you pick a private facility, be very cautious of a la carte facilities where rates can rise dramatically as care needs increase. With a sudden medical event, such as a broken hip, this can mean a sudden increase of thousands of dollars per month. So one family that I was brought in on to see if we could do something, we're in a private facility where the wife had now advanced dementia, but her husband, who only had mild issues, physical issues, was able to push her to and from meals, was able to help get her ready for bed, was able to help keep her oriented. And then he fell and broke his back. Suddenly, both of them needed 100% nursing care. Their rates went from $12,000 for both of them per month to $15,000 per month each. So it went from $12,000 to $30,000 a month in 1 month. So I would be extremely cautious, unless you're gazillionaires, of putting a family member into a la carte private care, and unless you are planning on moving them to another facility. And again, that can take a very long time, especially in these days of COVID. Okay, I'm finished talking about residential care, and so I'm going to talk about options for end of life care. There's a big misunderstanding about the difference between palliative care and hospice. Even within the healthcare system, the two terms are used interchangeably, and they should not be used interchangeably. Palliative care is symptom and pain management for a patient who has a life-ending diagnosis, something that could take years for their life to end. So let's say you've got advanced or end-stage kidney disease. That is a life-ending diagnosis, but it might be years by taking good care of yourself and medications and maybe adding dialysis before kidney disease will take your life. So palliative care manages all those things, just like I said. Dialysis is part of palliative care, so are all the medications and the diet. In the community, this can mean support for years or many months before end of life. Palliative care can greatly improve the patient's quality and enjoyment of life, and good palliative care can significantly increase the length of the patient's life. That's why you have come to this organization, because Parkinson's Society does an incredible job of increasing the quality of life for people with Parkinson. Be sure to apply for palliative status through your family physician or nurse practitioner. If you qualify, which is usually in the last 3 months of life, medications, equipment, and home care is free. So palliative care is symptom and pain management for a patient who has a life-ending diagnosis. In most hospitals, end-of-life palliative care is usually considered in the last days, weeks, or 3 months of life, depending on the hospital capacity. It's not a one-size-fits-all, that it's 3 months, because some facilities, the need is so profound that it can be days or weeks. And while many palliative patients die in hospital, the goal is pain and symptom management with a plan to return the patient home or to be placed in hospice. So St. Paul's has got the largest palliative care unit in the Lower Mainland. It's 2 full units, and most of the patients there are placed in hospice care or have chosen to go home and have the end of their life at home. Hospice care is the same. It is symptom and pain management, but it is for those who are actively dying. This can be at home or in a hospice facility, and is wherever possible based on patient preference. So studies have showed that 80% of people would like to die at home, and that is the goal, to try and get as many people as at home who want to die at home there safely. 24-hour day 24-hour-a-day care at home by public care staff and a hospice nurse oversight during the last 72 hours of life should be offered. However, during a time of COVID, this is not happening. I have not seen successfully one single client of mine or anybody that I've heard of getting 24-hour day care in the last 72 hours of life. If you want to die at home, you really should have a backup plan of having public or a private home care in place. Finally, a little note about medical assistance in dying. If your loved one has indicated they would like a medically assisted death, all health authorities have a dedicated team to help with the assessment process. All you have to do is Google medical assistance in dying, plus your health authority or even your city. So medical assistance in dying plus Vancouver will get you to the Vancouver Coastal Health Assisted Dying Program. Get this started early. Many people who have the medical assistance in dying or MAID assessment are deemed qualified, but they go on to have a natural death. They just want to have this in their pocket just in case things get out of control and they can't manage the pain and they feel like they're suffering. Leaving this part, this until the patient's health status is failing may mean that they may not qualify because they are not capable at the time of the application, which is necessary under law, and currently it is still necessary that they are capable when MAID is administered. So do not leave this too long if this is something that a loved one has expressed. So that concludes this very fast trip through our healthcare system and how to begin the navigation process. I want to know if there are any questions right now and if there's anything else that we should be talking about. Alana or Amy, can you chime in here and let me know what's going on? Oh, somebody is typing. Thank you.
Thank you. Oh, thank you so much, Connie. That was very informative, very helpful. A lot of good, important information there. So we really appreciate you taking the time out and doing this webinar for the Parkinson community. Also, I don't see any questions in the chat box, but you may email Connie directly. I have her email there and she's happy to respond. Um, Other than that, if there are no questions, unless there's something you would like to add, Connie, I think we can wrap things up here.
Awesome. Well, I thank so many of you for staying on the line. It's been a very long presentation. I really appreciate that. I did take a lot of time, a couple of years, to write the book on advanced care planning. The first half is on empowered patients and empowered caregivers. And the second half is on advanced care planning, and a huge stack of resources is available at the end of the book. So you can simply find it by typing in a Google search on advanced care planning plus my name, and it will come up. I know that we have actually sold out of books in print, and they are being printed right now. So I highly encourage you to, not just for my sake, because I don't make a lot of money per book, but for your sake and for those people who you love, to consider buying this and maybe putting it under the Christmas tree for a lot of people. And I want to thank you guys so much. And I really hope that you will join us next week and invite a whole bunch of people, especially those who will be just making will be your decision makers, or will be the alternate decision makers for the people you are caring for. Thank you so much.
Thank you, everyone. Have a great afternoon, and thanks again, Connie. Bye bye
Thank
now.
you. Bye-bye.